Hello, everyone, and welcome to the CoROM podcast. This is where academic medicine meets remote, austere, and resource-limited areas. With me today is Simon and Jim. Simon Ruparelia and Jim Allen have been on the first cohort of our Bachelor's of Remote Paramedic Practice. Jim, can you say hello and a little bit about your background?
I'm Jim, and I have a military background and an overlanding background, and I work with media organizations, training them for hostile environments and looking after them in these places, and that can be anything from a war zone to a jungle with a film crew. And so I look after them security-wise and medically-wise in these places. And I started a long time ago on these medical courses. As I grew into the job, I needed more medical experience, so I've always looked towards CoROM and grown through that way.
Good deal. Simon, can you introduce yourself? Give us a bit of background.
Hi, Aebhric. So I'm Simon. I'm originally from the UK and now work in healthcare marketing in Singapore as the day job. I'm a third-year student on the bachelor program, and I've spent my clinical hours at KCMC, Tanzania, already. So I'm really embedded in the program already and heading towards the end. I see the end in sight now, which is great. I'm also on the Wilderness Medical Society Fellowship candidate. Process is probably going to take me a few more years to complete as well. So aside from the day job, then this is my one other true passion, and I dedicate most of the time to that.
Good deal. Jim, are you on the farm as well?
I think I was, but I think it's lapsed. I've had a manic year, and a lot of things have lapsed. I've moved and renovated a house, so I think I've let things slip a bit.
No worries. We can get you back on track. So, Jim, why did you choose the CoROM Bachelor's program? How did you find us? The first 2 years of the program, how have you found it?
I started my paramedic program a long time in the predecessor to CoROM Merit, because I started off, I was actually put in places as being the medic and realized that I wasn't actually, I was way out of my depth. And so I came back to CoROM to build the knowledge and become a better medic. And I say I'd already done the paramedic side of it, and then the degree part wasn't actually there when I first started. So when I came back, did the first year 4 or 5 years ago. And then so I came in at year 2 to carry on and build into the degree program as the degree program developed. I don't know, I must have been at the right place at the right time, and it all came together sort of right at the beginning. So I've kind of grown with CoROM at the same time as growing personally. You kind of rode the wave, didn't you? Yeah. The program has sort of grown, and we've slotted in with that, because actually if you look at it, all the time and effort and studying to do the paramedic, it made sense to carry on and study because being from the UK, the paramedic qualification is not recognised that well. So by having a degree with it, actually, it opens a lot more doors, and people say, "Oh, you've got a degree in it." Oh, right. So it sort of makes it a lot easier in the UK having a degree, as well as the European paramedic qualification.
So Simon, how did you find the college, and what made you decide to do the Bachelor's of Paramedic program?
I guess there's some similarities in my reasons, same as Jim. I had a background in the British Army Reserve, and I trained as a combat medic. And then from then on, when I was doing my day job, I had a few years of search and rescue training on the side as well, urban search and rescue in the UK. And then 2 working stints in East and West Africa at an EMT level, which really just blew my mind as to what I could do and what I couldn't do. And I think that was the moment where I realized that I had so much holes in my knowledge, just like Jim is saying, and I needed to approach medical education in a holistic way. So the paramedic program offered the solution through CoROM, and it was a case of back to the basics through A&P, and then onwards through tropical medicine and the clinical time that I've already done, and I still got to do. So all of that was already laid out. You already had the foundation for that, and that was what was really appealing. I think the biggest draw for me was the austere and remote element anyway, for sure, because I had a limited experience in that, and I knew I loved that environment. And the opportunity for the clinical placements in the places that I loved going to, which was in Africa and then beyond, and the opportunity to go to do other placements elsewhere. So I don't think I was ever going to be actively working in an urban setting, definitely not in the UK. I haven't been there for many years. So this was a program which was really spot on to my passions, the holes in my knowledge, and then really where I wanted to take it in the future.
But also with the program, right, if you look at like becoming a paramedic in the UK, you have to go to university to do it. You have to stop what you're doing, stop earning, hand your job in, and you have to go to get a degree. This program allows you to carry on doing your job and study part-time, and you have to commit to it, to go to the clinical programs and into Malta and everything, but it allows you to continue working and earning money and paying mortgages and still study. And that's another thing about the program that's a big draw.
Yeah, that's absolutely right. I think for me, the ability to fly around the world, to do those placements and do them well and attend the training, that takes commitment and time and money and effort, and having a day job and being able to fit it around the day job was an important factor. So absolutely, by far. I think also having an employer who was very understanding, especially on the clinical time, allowing me to do the clinical time in the stints and timings that I wanted to do it, was very good as well. So the stars aligned, and we ended up on the program, and so far so good. And now we find ourselves in the third year, which is fantastic.
So what do you guys plan to do with this, Jim?
Well, for me, it kind of cements everything together, I say, and allows, when I deploy overseas, say, looking after a TV film crew, they're filming some rare birdie and we're going to some jungle, and I'm tasked as being their medic. I have a tele-conversation with the doctor, who's the top cover, and he goes through your medical qualifications and what drugs you're taking and all that sort of stuff. Having more qualifications and more something like a degree, they don't sort of necessarily see the paramedic qualification as they go, well, what's this? And then you have to explain it, and you go through it. I think it just sort of makes it easier for them to sort of go, okay, yeah, you know what I mean? It sort of relaxes them more. They can relate to it, I think, a lot more by having a degree. The thing is with qualifications, it doesn't matter if you've got an Australian qualification, American qualification, a British one, a European one. There's always crossover, and the people who, from, say, if you're an American looking at a European qualification or a British qualification, where does that actually sit? And I think when you actually sort of say this is degree level, then there's a sort of a line, so they can sort of agree on that. That you've been well drilled.
I think for me, I'd like to specialize eventually in critical care transport, in particular, focus on remote area evacuation or remote area support in kind of an intensive care environment or the austere version of that. I think both the challenge of acute clinical management of a patient with the logistics of an evacuation, that's just one big problem solving hairy exercise, right? Which I find really stimulating from an intelligent point of view, from the environmental point of view. That's motivating. That appeals to me. I want to be in that environment and challenge myself to do that best level care, and as well solve all the other issues of evacuation or next level care or wherever that may be. So that's where I want to head to. But I think that's way into the future. After I master the basic skills. In the shorter term, I'd like to work towards my IBSc exams. Critical care or the flight paramedic, kind of considering what is the best option now, and that will just underline my skills at that level, and then we'll take it from there.
You're totally qualified to take those now. I mean, after the first year, you are a paramedic, and you can sit these board certifications. Go for it. And they have this new board certified wilderness paramedic as well. That's coming out shortly.
I think this is an interesting development, because one thing that drew me to paramedicine in the first place was because it was so young and it was evolving. And on the previous podcast, you heard Dr. DeMello talking about the fact that this is a profession that needs to uncover the data within it. And that will come. It's been around for 10 years or 20 years or so, right, in an urban and a military setting. But beyond that, there isn't that data and that background. So what's exciting about the whole profession is where it could go and the evolution of that. And then along with that becomes the qualifications, the frameworks, and those specialist exams like the IBSC's wilderness one, which is very exciting for recognition, for new job opportunities, And that will just draw more and more people in to look at the profession as a very strong framework, evidence-based profession, which is part and parcel of the medical world, and that is very exciting to me.
Yeah, there's definitely room to grow. In the States, paramedicine has been around since the 70s in a very limited fashion. It's underneath the Department of Transportation. It's not a Department of Health issue. And paramedicine, if you look at from the European, Australian, and I'm putting UK and European very loosely there, but the paramedic world is young. I mean, we're looking at early 2000s that it started getting any type of traction. In Ireland, we didn't have anything until 2002, I think it was. They sent a bunch of lads to Boston to get their NREMT, came back, and suddenly there's a FEC paramedic, and now there's a master's advanced paramedic. And of course, the Brits, they are the world leader. They have their master's level practitioner, and we designed the master's of austere critical care as a austere side of that practitioner level. But watch this space. There's going to be a lot of advancements and changes, and we're trying to make this scientific and academic and research based, which brings me to the next question. Can you guys tell me about a clinical case that was of interest to you, Jim?
You know, I had the opportunity to when we were in Joburg in Tambo Memorial, and you've got a lot of gunshot wounds and things like that coming in quite regularly. If you mention a gunshot wound, say in the UK, it's like all the police are all around and everyone, it's a big fuss and everything like that. There, it's just like it's common day thing. And so you have a guy comes in. We had a prisoner who, well, basically he had broken into someone's house and he'd been shot 5 times. Mostly in the butt, and dealing with him in the handcuffs, you know, I mean, the police wouldn't let him be unhandcuffed to the bed, and you know, just dealing, you know, with him. And we were actually suturing some of he was still bleeding quite heavily, and they were just putting pretty big sutures into him, just to shut the bleeding down, start the life support on him, still in handcuffs. You know, it's the reality of the place. You know, whereas you know, like human rights and all that sort of stuff weren't so involved. It was more he was a criminal and he wasn't going to get away, and there was no way with his injuries he was going to get away. But you know, but you were trying to do life-saving trauma medicine on someone who's strapped to the bed, and the police are there armed guard. What should you do? And the doctors were fantastic, because the way they treated us was they treated us quite seniorly, and we were able to do a lot more than under their guidance than I would ever be able to do anything in the UK. And so you learn very quickly, because it's very, very hands-on, and it's very, very, you know, very, very serious. I don't know where I've ever felt anything like that. There is, you know, in Joburg, where they're actually, you know, allow you to do what we were allowed to do under those guidance of those doctors, and it was fantastic being able to save the guy's life. Yeah, so that was quite a poignant casualty that we dealt with.
The case that stands out for me is a young male, 15 years old, presenting with unspecific abdomen pain in the ER when I was doing my clinical time in Tanzania. In this case, I started down my checklist. I assessed him, reassessed him. I asked all the pertinent questions, but I couldn't understand the symptoms. It didn't make any sense. I couldn't make head or tail of my findings. And ultimately, the attending doctor assessed the patient and concluded that the patient had some psychological issues. And he had a long discussion with the patient about why he had skipped school, made his excuses to come and get help in the ER, and that ultimately that patient was discharged with follow-up. But what was stark here and why it stands out, is that in my rush to assess this patient, I was really treating everybody like a production line in the ER, and just going through the motions. And as I got into it, this is really one of those first cases when I first was getting to grips with becoming competent at the basic observations and basic taking of blood and so on. And so I was just there to be more efficient. And I was missing the point of assessing that patient thoroughly and holistically. And so treating patients like the production line in the ER is, of course, a big no-no. And that was a massive wake-up call for me. So it stood out. I mean, it underlined the importance of of personal social history anyway, but it just stood out as the case of stop, look what you're doing, and treat people like people, ER or not ER. And that was the case that I will always remember.
That reminds me, I was spending time in KCMC there in the base of Kilimanjaro, and this hiker, somebody who had been up the mountain, came down with difficulty breathing, shortness of breath. So the first thing we're thinking is HAPE, and even though as they descend, their symptoms get better very quickly, but we're checking this patient out, getting differential diagnosis, and just noticed a high temperature, and Jason Jarvis's voice comes in the back of my mind saying, any temperature, anywhere in the tropics, you have 100% malaria until proven otherwise. So I'm like, okay, why don't I just get we're waiting for the chest x-ray. Why don't we just get, sure enough, this expat coming down the mountain with HAPE had Vivax, malaria Vivax as well. So yeah, you've got to not be blinkered in austere environments, isn't it? You got to think broadly, and city-based paramedics, I've spent years and years and years in the back of the ambulance, and it's monotonous to say the least. It's a lot of drunks, and you have them for 10 minutes. And I very rarely got down to D in my CABC algorithm, because as I'm getting down to disability, we're backing up to okay, well, there you go. No idea what happened to them. For us, we're stuck with these guys for ages, and we have to go through prolonged field care and reassess and not get myopic. So I definitely, I'm happy I didn't miss that, focusing on his difficulty breathing, shortness of breath, and missing the Vivax.
It's when you go somewhere remote. I mean, we're dealing with mostly like military young men and stuff. And then when you go somewhere remote and then someone hands you a baby and then it goes, the baby's ill. And then you're sort of like, okay. And you have to go through it all the basics to go through it, because, you can't ask the baby what's wrong with them, and even with the language barrier, you can't ask the parents what's wrong with the baby, so it's down to your skills in the remote environment, because you do have to sort of really go right back to ABC and all that sort of stuff, just to get anything out of it. So yeah, you can get a hospital pass like that sometimes. That's puts you on the spot.
Pediatrics, I found getting out of the Army, the pediatrics was the most difficult for me, because we just never saw them in the Green Berets unless we were doing a FID mission or something like that. And so, yeah, getting on an ambulance and having this squishy thing that's screaming, and what am I supposed to do with this? Then the learning curve was astounding. And it wasn't until I got to KCMC, and when you can go into the ped ward and just see case after case after case after case of all of these 18-month, 3-month-old kids, that's where you become proficient. And same with geriatrics, and the beauty of doing what doctors do, isn't it? This is why doctors are amazing. They do 6 years and then 2 years of foundation, and then their intensivist training, and they see patient after patient after patient. For us and paramedics, we don't have that much time. So that's the beauty of, I found, at KCMC and Joburg as well for trauma anyway. But yeah, just seeing case after case after case, and finally get proficient in a very small amount of proficient compared to docs, but that hasn't been the challenge.
Yeah. On the course, you do learn the foundations of the pediatrics and everything. So you do have academic knowledge, if you can remember it. And then, so when you're with a pediatrician, and they're sort of just going through their routine, like they go through it every day, and you watch them even just intubate, a pediatric, it's like their hands just glide and it all happens, and you're sort of going, okay. They obviously are well practiced and things like that, but it's stepping into that sort of world of, you're quite frightened, but you're very nervous when you're touching small children in a hospital setting. I must have got to clarify that, because it's like you said, they're like the small squishy things, and you're going, you're so frightened of hurting them, doing any harm, and then you've got stick needles and everything in them, and you can't see veins on little babies and stuff. So the pediatricians they know where they are, and they just stick them straight in, and it's getting through it, stepping out of a comfort zone and going into something else, which it really is.
I think pediatrics is probably one of my most rewarding experiences on my clinical placement, because what you thought about age and weight and all of your knowledge You pull out your tape and here it is, and that's it, and that's the size, and all of that goes out the window in an environment that's austere, or you're seeing patients from the tribe, or they are at a different development level to what you expect in the country that you've brought up. And I have kids myself, and I'm always trying to compare their age and their development level to the kids that I see, and it's always wrong. It's always off completely. So it was rewarding in the sense that you had to reset your thinking and work through the new challenge. That is, okay, don't assume anything, go back, start again, and work through this patient, which was brilliant. So I found the most rewarding time was working on the pediatric ward.
I wanted to ask you guys kind of a big picture questions, and you've been part of the college long enough that I feel comfortable asking this. Where would you like to see the college go? What direction would you like to see the college go? What programs or what things that we should be doing that we're not doing now?
I mean that's a tough one, because actually the college has evolved so much in the time that I've been with it, and from doing my EMT and MIRA, and then going all the way through the paramedic, and then now there's a degree program, and then there's a master's program coming, and things like that. It's come a long way, and there's also now the specialist parts. I think, I don't know, maybe some sort of a school that's or attachment that is in a really rural, I don't know, maybe jungle setting. Some of the times I've been to these remote places like in West Papua New Guinea and everything, when you turn up, you turn up as the white guy, and they automatically think you're a doctor, and they don't have any doctors, and all of a sudden everything comes to you, and the film crew go, oh yeah, he's the medic, and all of a sudden you're this doctor, and you're trying to save everybody, and you get queues people outside your hut, because they don't have the medical. I don't know, maybe something that's in somewhere like that. Maybe it doesn't have to be so remote, but it's a very good experience for people to sort of realize that actually you're in somewhere where there isn't that much medical. You have really limited resources. You obviously have top cover to phone if you're unsure, but you can't X-ray. Obviously, you can ultrasound and things like that, but you can't. When someone comes into hospital, you sort of give them blood gases and all that sort of stuff, and they get all that, and then you read it, ECG and all that. They get all that sort of readings, and then you sort of make an analysis and everything. You're very limited to do that. In the sense, if you've got 50 people outside your hut and you've got your one little ECG, and something remote like that, and under some sort of guidance scheme, where there's doctors on hand to sort of go, guide you through it a little bit.
CoROM camp, field camp, yeah. Aebhric leading the charge, fantastic.
Jim, yeah, I guess we can bounce that one back and forth before we hand it to Simon. It's been up until this point, we have focused on academic learning, which means that we had to have you with an academic provider like Dr. Samir that you saw in Joburg, and Dr. Sakita, who is at KCMC, that you're always under the watchful eye as you go through the program. So Jim, I'm delighted you mentioned that, because that's been on the back burner for a while, only for people who are graduates, people who have experience that won't be dangerous whilst they're in a remote clinic in Belize or Borneo, and be able to have set up the telemed so that they can always phone a friend. I would like very much to look into how we can do that. PNG, it's got to be it's got to be safe. So like Borneo, we've looked at some of the options there. We've looked at options in Belize. Where else would you guys think that this would be a good location?
There's Nicaragua. There was some guy set something up there, and there was somewhere in Asia that people were doing something that's in the jungle, and I'm not sure whether that was northern Thailand or somewhere like that. Yeah, like you say, and it's got to be obviously safe, like security wise. Yeah, it's got to have good comms to have the the doc on call. If you're going to have to do something that you're trained to do, but it's beyond your remit in clinical terms. So you've got to do something under the guidance of the doctor. You want to be able to make sure you've got a good comms on that. So it doesn't want to be like so remote in the training. You can't actually achieve what you're trying to set out to do.
We did set up, before COVID, we did set up a clinical attachment under the guidance of Dr. Schertz, who's on our faculty. He's a former 18 Delta Special Forces medic, and now he's an emergency med doc. We flew him and Jason and I out to the border of Myanmar in Mae Sot, Thailand, and we set up a clinic on some of the Karen civilians who get across the border from Myanmar into Thailand, and they're literally living in a dump. It was 20 square kilometers of just rubbish, and they would go in and harvest rubbish and sell it, and that's how they would get their food and income. And we were setting up an impromptu clinic and treating a lot of the problems they had. We were hoping to get falciparum, but unfortunately, Bill Gates removed falciparum from Western Thailand, but with lots of Vivax. So that is something that we've looked at, and now that the pandemic is coming into a manageable situation, maybe we can relook at going back to Thailand or can look at Nicaragua. Simon, what are your thoughts on directions of the college?
I think I'll start with continuing the education or the academic element, which is the college has a great reputation now for, especially because this is a small community and a very special community of like-minded people, which is a great feeling to be part of. And the college has proven itself because of the people who are in the college and those who keep joining the college, and therefore we benefit as students from all of that network and that ongoing training that we get from it. So I think what I'd love to see what the CoROM view on continued education is, or championing an alumni network of the students for the postgrads as well as the paramedics who are coming out of the BSc program. That's less of an immediate need, but a great opportunity for the future for both the college and the students. I get a lot of interactions or a lot of great knowledge and info from the interactions that I have with my peers, the other students who are on the course, for both career options, for training, for exploring where paramedicine is going, to my earlier points about how this is such an evolving specialism and career opportunity. So championing of an alumni network, as well as then framework for some sort of continued education in austere medicine. I think college is very best placed to provide that. And on that point, the field guide, which is of course trumped and pushed by the college every time you get a chance on a podcast, but it is really well received and popular. And so there is a demand for that. And we are the first batch who used the paper versions before electronic versions came on board. And even then, it was a valuable resource, albeit you had a big chunk of paper to carry around with you, right, in those days. But there is demand for that in the austere environment, obviously, or ironically. So an evolution of that guide into different platforms or formats, along with the evidence-based protocols or templates that you wish to champion, would be, I think, a fantastic addition. I know that the field guide evolved into or has a drug guide compendium with it as well, which is fantastic. That type of evolution is in my mind is spot on what the college can offer the world and will be highly regarded for it.
I still like the paper version for when you go in the jungle, though.
We have emails each week of people whinging about the lack of paper, and I agree. I'm old school. I have both the virtual and the paper, and I'm reaching for the paper far more than the virtual. But what the virtual does is search.
Yeah,
that is awesome, where you can do a quick search and find everywhere that it's mentioning the abdominal assessment at Dr. Germs. I was writing an article on that one and being able to quickly find where that pops up. We are looking at branching out. So a Trop Med field guide, critical care, austere critical care field guide. We are open to expanding that a bit. I think looming is the third edition of the field guide, which needs to be discussed and upgraded a bit, but we'll get to that. It is popular. It's the field guide is located on 7 continents, and we definitely have a running start. And I'm open to hearing from our alumni, our students, and interested parties on how we can improve that.
The other thing is like I liked in the field guide was actually does the burns calculations and and for the drugs and how much fluid you're going to give and that sort of stuff. Because when you're actually learning it and you're studying it and you're working out the long way, and then all of a sudden you get this a calculator that does it for you. So in real time, when you're actually using it, you can come up with the figures without sort of wasting a lot of time with a pen and pad and a calculator and trying to do it. You can just put the figures in and it comes up with and then so you can start your procedure off. Those sort of things, those calculators are golden.
Michael Klopper has done a fantastic job on adding additional options that we can't have in a paper field guide. His drug guide is spectacular, as well as the calculators. And we'll continue to add those. Simon, you mentioned alumni. I'm glad you did. Dr. Grech, one of the founders, is our college registrar, which is in charge of the alumni network. And COVID has caused vast amounts of whirlpools to navigate. And that has been our focus, to just continue supporting you whilst this major world problem has happened. And now that we're putting that into a nice little box, I think we can relook at this. And tell me how you would see the alumni network and what suggestions you have to Dr. Grech on how to develop this.
If I look back at my previous studies, I already have a degree from many years ago, and that came with its own alumni connection through the university. It's a case of the professional development side more than it is the social side for me, because we are ultimately working on other sides of the world. But you do want ability to not necessarily compare yourself with peers, but try to get inspiration from them and uncover the professional training or knowledge that you might not have had time to research, had time to find. So it's a hugely valuable source of knowledge, and it's with people who have come through the same program as you, who know the same as you, who have shared experiences in their clinical time and so on. And so when you ask those questions, you get the right type of answer back, whether or not you're looking for equipment or you're looking for education or you're looking for placements, etc. So in our world, paramedicine is very vocational, and that is a hugely helpful network. And it's actually part of why you would join a degree program, if you can then have that lifetime network with you for the rest of your days. I think is a great opportunity for the student or the graduate once they've graduated, and as well as the college has an alumni network that they can reach out to for both uncovering new technologies, new placements, or new faculty members even. So lots to be gained by keeping in touch on both sides.
I think we'll have to have a follow-on conversation with that. I think we need to, because we're finally getting to that point, right? You guys are the first alumni, and to get through the program, and we're going to have more and more people joining those ranks. Let's create something that's going to be beneficial and maybe provide a clearinghouse for research or things that are going to push austere medicine forward. I think the alumni network can spearhead that. I wanted to open this up to kind of a final suggestion or any points that you guys would like to bring out, or any stories or anything that you would like to mention as we wind up this podcast. Well,
for me, it's like I say, I've been with the college now quite some time, but it's actually there is a kind of family feel. I mean, I when we popped over earlier in the year to do the ultrasound, and I met you and Dr. Winston again, and it's kind of like, every time you sort of go back, because when you're in your own sort of world studying, and then you come back to Malta and you meet you guys again, it's like you can, oh yeah, this is, there is that sort of, I don't know, there's a warm sort of spirit, and it's quite nice. That's one of the things about the college that is good. It's not so massive. Everybody kind of knows everyone, and it's like, you get to know people over the years, and that's a real draw card. You know what I mean? It's like, it's not just about take your money, do this, there's your certificate, and like when you're doing a course, and it's like, oh, how are you doing? What are you up to now? And there's that sort of, I don't know, warm glow feeling in the college that's and everyone I've met that are on courses there has got into that sort of mode as well, and it's a nice feel. It's one of the only places I've ever found it in training, is that there is that nice sort of family feel to learning. It's not just ticking a box. It's people genuinely interested in you learning and passing on knowledge and sharing knowledge.
I think for me, the opportunity for the college to become a global center of excellence is there, and it's proven because of the environment that you are operating in. And that's not in the backyard of Malta for most of the time. So having a base in Malta, you're huge in comparison to a base in Malta and a school in Malta. And that is a valuable addition to the world of medicine. So I would love to see the college taking part in some of the wider tropical medicine conferences in this side of the world where I'm based in Singapore, reaching out to India, Southeast Asia, and demonstrating what the college can offer, because those are the communities where ultimately the paramedics who are going to graduate from the program are going to find themselves working. And that's our niche area of expertise, and it's very valuable and in demand. So really the college is a huge global opportunity to be fronting and driving austere and remote medicine forward.
I think that's the task and purpose that the four founders had in mind when we created this in 2016. And it's going to be carried by you lot. You guys, the two of you are the plank owners of the 3-year program. And I see that the only way forward is to have the graduates, the alumni network, carry that and push that and create the global clearinghouse of austere medicine. Yeah, our faculty will push, of course, and our doctoral students are going to be doing their dissertations here in 2 years, and there's going to be a bunch of different groups that are going to push us forward. But that is my hope, and that's one of the reasons that I created this, to have a global community. And Jim, you mentioned family. There's no way that is not going to have space in the college, no matter how big we get. That this is about teamwork. This is coming from my special forces background. You're only as good as your team. Every team member brings something into this. So somebody coming in for a 5-day REMS course, and only a 5-day REMS course, still brings in something. And I still learn from students coming in with no medical training whatsoever. They do a REMP course, and they're doing this weird tie with the improvised traction device that I've never seen before. I am totally stealing that. So that's a team member, as well as you guys, along with Jordy and Grigori, the 4 people who are going to graduate first of our bachelor's program. You're definitely leaders within that team. And it is my intention that as you graduate this time next year, when you have your bachelor's remote paramedic, I would like very much for you guys to become leaders in creating this collaboration, this camaraderie, this world network of austere medicine, and try to make the world a better place. I'd like to thank Jim Allen and Simon Ruparelia for joining us. And I wish the best of luck for you too.
Thank you.
Thank you, Aebhric.
This has been a presentation from the College of Remote and Offshore Medicine Foundation. If you would like to earn CPD credit for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credits, free access to the virtual field guide, and discounts on our e-learning courses. You can join the team on the college website, which is CoROM, CoROM, CoROM.org.